This presentation is for the 3 Center North Hemodynamic Skills, which are necessary for you to safely take care of a patient with an arterial line and pressure monitoring, as well as if you had to take care of a patient with CVP monitoring. We're going to cover basic hemodynamics, arterial line setup, monitoring, and the waveforms. We're going to go over CVP monitoring, waveforms, troubleshooting for both, as well as the nursing implications and responsibilities. The objectives of this lesson is to identify the appropriate steps for setting up pressurized lines and ensure the accuracy of the system. So we'll go over how to set up your arterial line and some troubleshooting tips. Also to recognize and interpret your CVP waveforms as well as the arterial line waveforms. First, we'll go over some key hemodynamic parameters. So these things you kind of really need to understand to be able to really look at what's going on with your patient based on those CVP readings, as well as your arterial line blood pressure readings and why they have these interventions in place. So we'll review the cardiac output, cardiac index, stroke volume, preload, afterload, contractility, and heart rate. First, we're going to talk about cardiac output. Cardiac output, by definition, is the amount of blood ejected by the left ventricle in 1 minute. The equation for cardiac output is stroke volume times heart rate. You're going to want to make sure you remember that equation. Cardiac output has a lot of determining factors, so preload, afterload, and contractility, and the patient's heart rate all go into the factors that are going to affect how much of that blood is coming out of the left ventricle each minute. Normal resting cardiac output for a healthy adult is 4 to 8 liters per minute. So stroke volume is the amount of blood ejected with each beat. Stroke volume basically is the amount of blood that is put out by that left ventricle of the heart in one contraction. So each contraction is that amount of blood that's coming out. That's your stroke volume and what we're measuring. So preload, afterload, and contractility are the factors that make up the stroke volume. And normal stroke volume in a healthy adult, is 50 to 100 milliliters per beat. Next is preload. So when you think of preload, you always want to think of volume. So volume is going to be the primary determinant of the blood filling the ventricle during diastole. So when anyone's thinking about your number of your preload, kind of look at their volume status. And the definition of preload is the degree of which muscle fibers are lengthened or stretched prior to contraction. So you can see how your volume coming into the heart would affect that. Alterations in preload. So again, you want to think about volume. So these are things that you want to look at when you have an increased or decreased preload based on your measurements, based on that CVP. So an increased preload could be caused by increased circulating volume. So did your patient get a lot of fluids? Are they overloaded with fluids? Look at the big picture of what happened to them clinically leading up to that increased preload. Or venous constriction. So that would decrease the venous pooling and increase the venous return to the heart. So again, would cause that increased circulating volume into the heart. Things that can cause that are vasoconstrictors are a big one. A decreased preload could be caused by hypovolemia, so not enough volume, just the opposite. Mitral stenosis, and then the opposite of the vasoconstrictors would be vasodilators. So think about like your nitro. Hypersensitivity reaction, cardiac tamponade, and constrictive pericarditis are other things that can also cause decreased preload. The goal with your patient is to optimize their preload. So you want to get them back within that normal range, that 2 to 6. So this is things you can do to treat the alterations in preload. So either the increased or decreased CVPs. So if you have an elevated preload or high CVP, you want to give diuretics and vasodilators like nitroglycerin. If you have a decreased preload or a low CVP, you want to give them volume and then also antiarrhythmics, because if you think about if you have a dysrhythmia, you're not getting enough cardiac output out because the heart's not pumping effectively, and that will decrease your preload. Next, we're going to go over arterial pressure monitoring, and this is just an example of what the art line will look like on your patient. Arterial pressure monitoring. So the definition is an indwelling catheter placed in a systemic artery and connected to the hemodynamic monitoring system. Arterial waveform inspection can help rapidly diagnose the presence of valvular disorders, the effects of dysrhythmias on perfusion, the effects of the respiratory cycle on blood pressure, and the effects of balloon pumping on ventricular assist device or blood pressure, which you're not going to be doing in the progressive area, but just another reason they do put art lines in. They're frequently used for or post-CEAs here, just to monitor their pressures. So indications, any patient that needs continuous readouts of their systemic arterial blood pressure, or if they need vascular access for frequent arterial blood withdrawals, so frequent ABGs. This is a visual of the pressure monitoring system, the components. So you have your catheter and pressure tubing up at the top, you have the pressure transducer, monitor cable, a flushing system, and then the inflatable pressure bag. This is your phlebostatic access, and this is the physical reference point on the chest that is used as a baseline for consistent hemodynamic reading. So this is what you're going to be zeroing and leveling to every time with your art line. This is the point used for transducer placement. So you find your phlebostatic access and you place the transducer right at that level to make sure that it is accurate. So the transducer should then be zeroed at this level to negate atmospheric pressure. So the process is you draw a line from the fourth intercostal space at the sternum towards the edge of the chest and down to side. Draw a second line on side of the chest halfway between the anterior and posterior portion of the chest. So that's the mid-axillary line running head to foot. Mark intersection lines on the side of the chest and place the transducer at level horizontal to that mark. And you're going to do this just by using your level, kind of imaginary lines. And this ensures accuracy of the pressure readings. And it's approximately the level of the atria. So you want to use the level to ensure the transducer is even with the phlebostatic access. It is a nurse's responsibility to ensure that the hemodynamic monitoring system is accurate by using your phlebostatic access and leveling. So you want to make sure you re-level the transducer with any change in the patient's position. So if the head of the bed goes up with the patient, you're setting them up for some reason, you need to zero and re-level to make sure you still have those arterial line pressures that are accurate. If the patient gets up in the chair, same thing, you're going to want to re-level that transducer. And this is just a visual showing you if your transducer is 1 centimeter above the left atrium, so above that phlebostatic access point, it's going to decrease your pressure by 0.73 millimeters of mercury. So say you're 6 inches off, you're going to be very off on your pressures. So same thing, referencing the system 1 centimeter below the left atrium increases the pressure by 0.73. So if the system is too low, it's going to increase your pressure. Too high, it's going to decrease the pressure. But it can make a big change in what you're looking at, so make sure it is accurate. Square wave test. The square wave test verifies the accuracy of the transducer-patient interface, and it should be done at the beginning of each shift. And also, if you question the accuracy of your pressure readings for any reason, do another square wave test. It's produced by a fast flush, so you just do a fast flush into the system, and you should see the square wave test produced on your monitor. You should see 1 to 2 bounces after the square wave before returning to the waveform. And I'll show you in the next page what it looks like if it's abnormal and then an optimal dampening. The second bounce, so you should have 2 bounces, second bounce should be less than 1/3 of the height of the first bounce. If it is higher than that, then you do not have optimal dampening. This is a visual of what optimal dampening looks like. So this is a good square wave test. So you should have only 1 block between the bounces. Your second bounce should be less than 1/3 the height of the first bounce. You should have a rapid decrease with the release of the flush device, a small overshoot of baseline, a small undershoot. So basically 2 bounces that look pretty close to this waveform, what you're seeing here. And I'll show you what under and over dampening looks like, and you'll be able to see it a lot easier what it looks like when it is off. This is an example of under dampening. So you can see that there's more than 2 bounces. So when you have under dampening, you're going to see extra bounces. And the second bounce is almost the same height as the first bounce. So too many bounces that are too high. So this means that the system is under dampened and the pressures are going to be overestimated. Over dampening is exactly the opposite. You're going to have no bounces after that square wave test. So you can see that there is no bounces after that big square is produced with the rapid flush. You can see the gradual descent down to baseline, so you kind of have that slurring down slope. There should no bounces though if it's over dampened. So the pressure is inaccurate. It's underestimated if it's over-dampened. Waveform troubleshooting. So if you do your square wave test and you see that it's over-dampened, these are some of the possible causes and things you should check. So look for blood clots in the line. If there's blood left in the catheter following blood sampling, so say you drew blood from your vamp and all of the blood did not get pushed back in, so you're going to need to flush the system to fix that. If you have air bubbles at any point from the catheter tip to the transducer, it can cause it to be over-dampened, so you would want to make sure you get rid of all the air bubbles. If there's a leaking in the system, so check all of your connections, make sure they're really tight. Any kinks in the line or catheter, maybe the patient has their arm resting on the catheter, can cause it to be over-dampened. And then if your pressure bag is underinflated or you run low on the fluids, you want to keep a close eye on the fluid inside that pressure bag. So under-dampened, some possible causes, again, air bubbles, so you want to remove them in the fluid system, or if you have too much tubing or non-pressurized tubing, you want to make sure you always have that hard pressurized tubing when you have the ART line, and then only make the line as long as you need it. So you want to make sure that the patient's comfortable and it's not pulling too tight, but don't put a lot of extra length on that line because it makes the system inaccurate. And then these pictures just show what the extra arterial waveform will look like. If you have a normal arterial waveform in the first box there, if it's over dampened, your waveform will start to look a little flat like that. If your system is under dampened, you'll see that high peaked waveform. These are the nursing responsibilities when you have a patient with an arterial line. So it's your responsibility to make sure that the system is always zeroed, leveled, and balanced. So you need to make sure you do that every 12 hours and as needed. So again, with any change in position with your patient, just to make sure that those pressures are accurate. You have to make sure you replace all of those white caps with blue sterile caps. Sometimes when they come from the OR, they might have that white cap on. You want to make sure you replace that with a blue sterile cap. And also with any time you're flushing, zero, leveling, you want to get a new sterile blue cap each time. The white caps can't be used because there's actually a small hole in them, so it will let air in and make the pressures inaccurate again. So you want to make sure that your pressure bag is inflated at all times and that there is enough fluid in that pressure bag. It makes the patient at increased risk for an air embolism because the bag is pressurized, so if it does run dry and you let air go in, it will go in rapidly and go right into the arterial system, right into the patient's artery in the blood system. So you want to make sure that you do not let that run dry. So check it at least every 4 hours, but I would just go in and kind of peek at it every time you're in the room. The tubing change is a little bit different than your IV tubing. You need to change it every 4 days. And then if the line gets changed, you would want to change all the tubing. And then if you have any issues as far as inaccuracy, just change all of the tubing. Check all your Luer lock connections every 12 hours in PRN. So if you're troubleshooting the line, you're going to want to check that more often. And then minimize the number of manipulations and entries into the pressure monitoring system. Try to make sure that it stays in place because they often go bad, and the patient can have a lot of bleeding and issues if there's circulation issues going on. Arterial line complications, so pain. It can be painful for the patient. If they are complaining of pain, please go and assess that site. Make sure that it's still flushing okay and that your site looks all right. Infection, the arterial line can get infected just like any other central line or an IV. Hemorrhage and hematoma. If you notice that you have kind of a bulging spot, there could be a hematoma there, or if the patient starts bleeding for any reason, you want to make sure you hold pressure immediately because it is an artery. Even though it's a small bore, it's still an artery. Arterial insufficiency can occur because the patient's blood flow to their extremity can be compromised. Arterial embolus, and then misuse and misinterpretation. So if the pressures are inaccurate and they're treating the patient based on those pressures, that can be a complication because they're misinterpreting what could be going on with the patient just based on inaccurate pressures from the pressure system. This is an example of why neurovascular checks are so important. So make sure you can still get a good pulse on the other side of the ART line, and make sure you're always checking the circulation in your patient's hand and fingers. So check for cap refill, color, temperature, sensation, and make sure you're checking that pretty often because these can go bad quickly, and you never want this to be the case with one of your patients. Arterial line removal. So when it comes time to remove your arterial line, these are the steps you're going to want to go through. So first you want to always assess the need for continued use of the arterial lines. If you don't think your patient needs it anymore, be an advocate for them and try to get it out as soon as you can. It's not comfortable for the patient and they are at increased risk for complications the longer it stays in. So first you do need a physician order to remove the arterial line, and then you want to assess their coagulation status. So either draw a PT, APTT, or ACT, or if they have a recent one that is sufficient, make sure you check that. First you want to remove the dressing and the suture. If it is sutured, they are not all sutured. Remove your catheter and then apply firm pressure for 5 minutes or until you achieve hemostasis. It could be longer than 5 minutes if they have prolonged bleeding. Apply a 4x4 dressing, and you can either secure with tape or Tegaderm, just some type of occlusive dressing. Make sure you document the procedure. And it's really important you put the exact time and date that you do remove the arterial lines, so when the next person is monitoring or if they have complications they're seeing, they need to know when that was removed and how long they need to be checking it. So what you want to watch for after you remove it is bleeding, hematomas, again, those neurovascular checks, check their peripheral circulation. If they have a loss of pulse, that could be an emergency. So make sure you're watching those pulses, circulation frequently post-removal. This is a visual of what can happen if you inject a drug into the arterial line. So the arterial line is just strictly used to draw blood from and monitor the arterial pressure. So you never want to inject anything into the arterial cannula or art line on any of the ports. So this is what can happen to your patient. It can cause skin necrosis, severe gangrene, limb ischemia, which could result in amputation or permanent disability for the patient. This is another slide that's just an overview of the nursing management. So your assessment is really important. Make sure you're always inspecting that site for any potential complications. Watch your neurovascular checks. Make sure you're checking the peripheral vascular status of that hand. Check your arterial flush line solution to ensure it's inflated and you have adequate saline still in the bag. Make sure you're doing tubing and fluid change every 96 hours or, if needed before then. And then your dressing. Replace any dressing that has a gauze underneath it every 2 days. And then transparent dressing is the same as with your IVs and central lines every 7 days. And it's also your responsibility to monitor the waveform. So do that square wave test. Ensure it's not over or under dampened. Zero and level the transducer. Never eyeball. You always want to make sure you're doing it with the level to make sure it's accurate. And then you want to post the strip and obtain measurements at end expiration every shift or if any changes occur. Next we'll go over your arterial pressure waveform and some characteristics. So arterial pressure represents the forcible ejection of the blood from the left ventricle into the aorta and out into the arterial system. During ventricular systole, blood is ejected into the aorta, generating a pressure wave. So that's the wave you see on your waveform on your monitor. Because of the intermittent pumping action of the heart, this arterial pressure wave is generated in a pulsatile manner. The ascending limb of the aortic pressure wave represents the increase in the pressure because of the left ventricular ejection. The peak of this pressure is the peak systolic pressure. After reaching this peak, the ventricular pressure declines to a level below aortic pressure, and the aortic valve closes, marking the end of ventricular systole. This closure of the aortic valve produces a small rebound wave, creating a notch known as that diacritic notch, which you can see in the picture above. The downslope represents diastole and is characterized by the long declining pressure wave. That diastolic pressure is measured at the lowest point of the diastolic downslope. The difference between the systolic and diastolic pressures is the pulse pressure. The normal pulse pressure value is 40. That's nothing you have to memorize, but just so you kind of know what's going on. This is an example of an arterial waveform, and this is kind of the strip you would be pulling. This looks very similar to that. So you can see where you can look at that rapid upstroke, and then you see the peak systole, so that's going to be your first number for your blood pressure reading. You can see the diastolic or diacritic notch, and then the end diastole, which is going to be your second number for your blood pressure. You can see that end diastole lines up roughly at the end of the QRS, so it's another way to kind of determine where the end diastole might fall. This is a practice example, so see if you can look at that waveform and roughly measure what the systolic pressure would be at that high point, and then the diastolic pressure. So locate the diacritic notch and go to the low point below there, and that's going to be the diastolic pressure. So see if you can look at this, and then we'll go over what the correct answer would be. So based on that waveform, the peak systole is 120 and the end diastole is 60. So your pressure based on this would be 120 over 60. And you can see the points they're referencing. The 120 was at that high point, and then they did the end diastole at the end of the, also lining up at the end of the QRS, which is 60. Next, we're going to move on to central venous or CVP monitoring. So CVP monitoring, it's a direct measurement of the blood pressure in the right atrium and the vena cava. CVP or central venous pressure monitoring can be achieved through the use of a single or a multi-lumen catheter that is positioned in the superior vena cava. If you have a femoral line, it's going to be in the inferior vena cava. And then you attach that to the pressure transducer, and that's how you achieve your CVP monitoring. Serial or continuous readings provide a method for directly assessing the right heart function and volume status, as well as an indirect method for assessing left heart function. So this just shows you that you can monitor it even through a PICC line if you had to, but as long as it's positioned in the superior vena cava. So usually you're going to want to use that distal or brown port of your central line. You can use a red or blue line of the PICC as long as it's in the SVC. Normal CVP in a healthy person is 2 to 6 millimeters of mercury, but it's more important to monitor the trends in CVP. So your CVP can vary from patient to patient just depending on their age, condition, what's going on with them. So it's more important to monitor trends. So if your patient has been at a CVP of 8 and they consistently been at CVP at 8 and stable, that might be normal for them. So don't be alarmed if it's a little bit out of that 2 to 6 range, if that is your normal for your patient. You want to look more that if they were at 8 and now they're at 16. So look for trends and changes. Why do we monitor CVP? It's a really great tool to assess that right ventricular function and also for fluid status. So that's why they want to monitor them a lot to guide treatment. With surgical patients, heart failure patients is another good one. Shock patients, they monitor a lot. So these are some of the things that CVP is elevated by. So overhydration, because that's going to increase that venous return. So maybe your patient got loaded with too many fluids during their surgery. Heart failure, we just went over a little bit. So that limits the venous outflow and leads to venous congestion. So if they're in congestive heart failure, fluid overloaded, they might want to monitor their CVP to see how elevated it is to guide their treatment. And then positive pressure breathing or straining can just naturally elevate the CVP, nothing that would need treatment. CVP decreases with hypovolemic shock, so low volume, so if they're hemorrhaging, dehydrated, hypovolemic shock from fluid shifts. Negative pressure breathing is another thing that CVP decreases with, but again, that's just normal from the patient's breathing pattern. This is a visual of the waveforms in CVP monitoring. So first you have your A wave, so that's your atrium contracting, and then your tricuspid valve opening. And from your A to your C wave, that's the diastole. So next is your C wave. You can see that's kind of just coming down before the X wave, which is your ventricular systole. So the X wave is the atrium relaxing, then filling, and the tricuspid closes. Then you have your V wave. You go back up, going towards diastole again. Atrium is tense, full, tricuspid is closed, and then you have your Y descent, atrium emptying, and the tricuspid is opening. Correct identification of the ways comprising the CVP requires correlation with the EKG. Since the cardiac and vascular pressures are transmitted through the fluid-filled tubing to a transducer, there's a slight delay between the electrical event and the corresponding mechanical event. So the A wave occurs after the P wave of the EKG just because of that natural delay, and actually may be observed anywhere in the PR interval. So that A wave can be after the P or anywhere in the PR interval. The C wave, if you can see it, you cannot always see it on the actual patient, occurs at the end of the QRS within the RT junction, and the V wave occurs after the T wave. The A waveform for a CVP reading can be found just after the P wave on the EKG and represents atrial contraction. By taking the reading at the highest point of the A wave and adding it to the lowest point of the A wave, then dividing by 2, the average or mean of the CVP reading is obtained. You can also draw a line through the middle of the A wave to derive this same number, which I'll show you what that looks like on another slide. This is another example of how you can measure the mean of the CVP value. So you locate the A wave within the PR interval, measure the top and the bottom, and then average these values. And you can see with that second waveform where it says the 14 millimeters of mercury, they just drew a line through the middle of that A wave and used that as the mean. This is again showing how you would measure the mean CVP value. So this is the other method where you can just draw a line through the middle of the A wave and derive the average value. So you can see they kind of just went middle of that A wave and coincided with 10, and that is the mean CVP. Next is a Z-point method, which I think is a little bit easier. This is really useful when you do not have P waves or you can't see the A waves, so the A waves are not visible. So this happens a lot with AFib. So the Z point coincides with middle to end of the QRS wave. It occurs just before the closure of the tricuspid valve. It's a good indicator of right ventricular and end diastolic pressure. So you're going to find that Z point is between the A and the C wave, where the A and the C wave should be. Even if you can't see that A wave really good, you can kind of see that little notch. That's your Z point. And you just make a line down through there, make sure it coincides with mid to end QRS wave, and that is your CVP number. This is another visual of that Z-point method. So you would just find the Z-point, which occurs mid to end QRS, line it up with your CVP waveforms, and then just read that Z-point, which is that little notch between the A and the C wave. This is another visual of finding that Z-point. So we're measuring the CVP waveform with absent A wave. So this is a paced rhythm. There's obviously no clear P waves. So you just go from mid to late QRS, line that up, and that's your Z-point. This is just another visual so you can kind of get used to what the CVP waveforms look like. So abnormal CVP waveforms, they are very common, and you'll see when you start going into practice that there's a lot of variation of what the CVP waveforms look like. So some common types are large A waves, which they also refer to as cannon waves. So this is when the atrium contracts against a closed tricuspid valve. So this can occur with a lot of dysrhythmias. So if they have a lot of PVCs, heart blocks, things like that can cause the large A waves, the cannon waves. You can also have large V waves. So conditions such as tricuspid insufficiency or if they're in ventricular failure. So the Z-point technique is going to be the most accurate to kind of prevent incorrect interpretation of these waveforms, especially when you see that there's abnormalities going on. Any change in intrathoracic pressure during inhalation-exhalation will vary the pressures in the heart and the large vessels. So you can see some CVP abnormalities. So the hemodynamic pressures will fall during spontaneous inhalation and then rise during exhalation. But if you have a patient on mechanical ventilation, which also would occur if they're on BiPAP or CPAP, the hemodynamic pressures are opposite. So they rise during inhalation and then fall during exhalation. So just remember they are opposite if they're mechanically ventilated. Some patients, not every patient, will have respiratory variation just based on the natural spontaneous inhalation and exhalation. So this is an example of that. You can see in that bottom CVP reading, they have that respiratory variation. So that's those large dips you see. So you can see where it says spontaneous inhalation, that's where you're seeing the respiratory variation. So what you would do when you're measuring the CVP waveform during spontaneous breathing, so this is if they are not on CPAP, BiPAP, or any mechanical ventilation, you're going to find the start of the pressure decline and locate the A wave just prior to the decline. So you can see they kind of went one waveform in front of that spontaneous inhalation, that dip there. And then they just averaged the wave and they got 12 for their mean CVP. Okay, so do this one for practice. Look down at that CVP where you can see that there's spontaneous breathing variation going on, and try to see if you can find the mean value of the CVP. So the answer for this one is 13. You can see the wave that they're pointing to right there. That's the wave that's prior to the pressure decline, and the answer is 13 millimeters of mercury. So they just looked at the point where it was the waveform before the inhalation. So we just went over how you would measure it if they have spontaneous breathing, respiratory variation. So a good way to remember the difference is patient peak, vent valley. So if they're on mechanical ventilation, you're going to actually measure in the opposite spot. So remember patient peak, where we measure that higher point before the dip. So you're going to do the opposite with mechanical ventilation. This is an example of a patient that is on a mechanical ventilator. So say they're on BiPAP. You're going to want to do the opposite. You're going to actually measure in the valley. So remember patient peak, vent valley. So see if you can find the CVP value of the patient in this waveform. So remember, go in the valley. Okay, so the answer for this one is 5. You can see which waveform they chose. So right, that first one, when the respiratory variation starts, they went into the valley. And that again is because they are on mechanical ventilation. Great job, you're almost done. You just have to click the link in the slide here, and it will take you to a short quiz just to kind of validate that you went through this module and you have an understanding of arterial pressure and CVP monitoring.